Hi everyone, I'm back, and today I'll be talking about sepsis 2. I have published sepsis 1. Before you can enjoy sepsis 2, I will advise that you please listen to sepsis 1 because I will not be going over so many terms and some, other things that I've talked about there, like all the definitions, the causative agents, the clinical features. I will not be talking about them now. I'll be talking about prevention, treatment, and prognosis. Now, let's go. PTP, prevention, treatment, and prognosis of sepsis. Many people will be interested in this, right? Because of the prevention. It's always cheaper. Let me put, it's even wiser to take preventive measures. Okay, prevention. Hand washing. Nurses are better off compared to physicians when it comes to hand washing. And physicians cannot take offense. Please don't. And one, let's face the facts. The nurses do more hand washing compared to us. Okay? It's a fact. Proper care of all lines. And trust the nurses, they will do better job also. But if you call us, we'll be there to help out. Replacements of catheters promptly when required to. The more we delay, the more the likelihood of sepsis. Hospitals must have a protocol to report unusual low or high temperature or signs of inflammation or signs of organ dysfunction. That should be written out. So many centers, they have it already, but if you are listening to this presentation and you are in other parts of the world where that is not done up to now, please get your computer or your pen or your paper, write the protocol out and save many lives. Okay? Report increased lactate. If you watch sepsis 1, I have explained in details. We don't want any lactate level greater than 2 millimoles per liter. We don't want that. And anything greater than 4, we are in trouble. We don't want that. Decrease white blood cell count or increase white blood cell count. Anything white blood cell count greater than 12,000 is not good. Any level lower than 4,000 is not good, okay? And neutropenia is scary. So absolute neutrophil count level report, please. Let the doctor take preventive measures immediately because it's cheaper than treating multiple organ dysfunction or severe sepsis, okay? DIC, wow. DIC, we don't even know what we're heading to once the DIC are certain, okay? And you know that with decreased platelets or increased bilirubin, PT, APTT, please act immediately. Even if there is no fever or cheese, if there is no rigour, but you are picking the values of PT, APTT, platelet level at abnormal range, call the doctor immediately, please. Still on prevention, put highly susceptible patients in private rooms. I don't want to use the word that will offend some to say isolation. No. Let's give them the honor and respect due to them, right? Good rooms, nice ones, but they're alone. And nurses know the protocols before they could go in, okay? And who are these people that should be placed in such nice separate rooms? Cancer patients on chemotherapy or radiotherapy. Please, affected individuals and family members, understand this with me, because the affected person will not even want the loved ones that will look after them to be in trouble. So they will comply, okay? And so there's a way we say it that will make them happy and they'll take it. Others that may be in private rooms are patients taking disease-modifying anti-rheumatic drugs, and they have other co-morbidities with them, okay? And some that are on immune suppressants, or elderly having certain comorbidities, and neutropenic patients. Neutropenic patients should be in private rooms. All the above, please make provision for private rooms. Maybe you write the government to build more rooms in your hospital. It's better to prevent this situation, right? Let's go. Warning sign at the door. The nurses will do that, okay? But if at your center or your jurisdiction you've not been doing that before, get your computer and put those up now, or your piece of paper and pen and put all those out, okay? No fresh fruits and vegetables, particularly to neutropenic patients. No flowers from gardens to the rooms of neutropenic patients. Prevent unnecessary visitation and limit the time that I'm going to spend. Discuss this in non-judgmental ways with the affected patient and their loved ones. Explain to the family members, okay, so that they will not pick offense, okay? Seek doctors and seek nurses. Please keep off. 2 ways, so that you don't pick what may kill you, or you don't transfer what you're suffering from to this neutropenic patient, okay? Put up a standing order as per the temperature, the blood pressure, O2 sat, respiratory rate, urine output, heart rate, and so on, that at this level, please call me immediately. Okay, we've done everything to prevent. We were not winning, and now we are down with this trouble. What are you going to do? Treatment. Airways. Check the airway. Okay? Look for all the orifices. Clean, remove debris, suction if necessary. How about breathing? Auscultate the chest, percuss, listen to the breath sounds. Is trachea deviated? Any obvious deformity at the chest region? Just do everything count the respiratory rate. Any peripheral cyanosis or central cyanosis? How about circulatory system? What's the BP telling us? What's the pulse? Fluid in and out? Hand sounds? Is it muffled hand sounds or distant hand sound that is telling you this is cardiac tamponade, distended neck veins? Giving us clue that we are dealing with another problem, right? Superior vena cava syndrome, cardiac tamponade, pericardial effusion. We have to rule out. Immediately, we set I.V.lines. Depending, you might not be able to put your I.V.lines at the upper limbs if you are dealing with problems along the upper limbs, like superior vena cava syndrome with distended neck veins and then cyanotic upper limbs. Okay, then IV fluid, Ringer's lactate, normal saline, depending on the value of the potassium and bicarbonate. If you have low potassium and bicarb problem, go for ringers. Otherwise, use a normal saline. Some will use albumin, but there is no extra benefit above normal saline. Okay. Intravenous antibiotics, yes, don't worry about that. We'll go through a long list in a bit. Arterial blood gases, because we want to know what we're dealing with. Are we dealing with acidotic situation or alkalosis? And of course, we need to know what the level of the bicarb is talking about. So, lab, you've taken sample to send to lab. If you go through the diagnosis during sepsis 1 production, please go over that. I will not be able to go over that here. That's why I said a lot has been said. And I'm not prepared to go over that so that I don't have 2 hours presentation. No, 1 video. No. So check sepsis 1 is about 30 minutes. Go over it, you're going to enjoy it. So you'll see everything about laboratory there. Now, review that lab results. Okay? We're going to check your lactate level, procalcitonin level, potassium, sodium, glucose, INR or PT, APTT, platelets, and of course, a lot of microscopic culture and sensitivity that I mentioned. So many swabs and everything like that. Blood urea, nitrogen, creatinine, albumin, bilirubin. Just please go over sepsis 1. Don't let me take all the time here. Chest X-ray is only if necessary. Okay? If you think this person is having pneumonia, this could cause pneumonia, and pneumonia could cause this. So let's keep moving. Bladder catheterization. Well, I've just talked when I was making sepsis 1 that long-standing catheterization could lead to sepsis. Now, to treat sepsis, we need catheterization. Well, it's not funny anyway. Check vital signs every 4 hours. And don't go solo. Seek help when necessary. Because the goal is to make sure that man or woman gets up and gets out, and you meet at the bus stop, concert, Super Bowl, anywhere, and have a hug or handshake, or he or she may snub you, no problem. But at least he or she is alive, right? So seek help just to get that man or woman back on his or her feet. So consult to infectious disease unit, consult to intensive care unit, consult to pulmonologist, as the case may warrant. Okay, I said the other time, don't worry, we're going to go over a long list. Yes, I'm now there. You can choose rigour lactate or albumin or normal saline. And if you think that you have supplied the deficit and want to have maintenance, 4.5% saline with D5 water is enough. You can give Tazocin, but you have to rule out allergy to penicillin. You may not use Tazocin, like I put it down here, because this is a brand name. It's a combination of sulbactam and papanicillin. Okay? You can use vancomycin, gentamicin, or amikacin, ceftriaxone, carboplatin, metronidazole, ampicillin, linezolid. You need to be careful with that. Daptomycin, ciprofloxacin, but in ciprofloxacin, you can't just use it for just everybody, because women, pregnant women, breastfeeding women, children less than 8 years cannot use ciprofloxacin. And if you think we are dealing with concomitant fungal infection here, fluconazole is available. The other time, that is, if you have the time to go through sepsis 1, I have categorically stated there that IV fluid might not be sufficient for complete resuscitation when it comes to septicemic shock or septic shock. So you will have to use vasopressors. Here is the list of vasopressors. So you can choose from dobutamine, dopamine, epinephrine, norepinephrine, or phenylephrine. Anotrope like milrinol or glucocorticoids could be used. You may choose to transfuse if you are dealing with refractory septic shock, with or without procalcitonin use. You also take care of the nutrition of the affected person. Dietitians could be involved, and you treat stress ulcer prophylactically. You can use neuromuscular blocking agents if you deem it necessary. Venous thromboembolism prophylaxis will be helpful, particularly if you are scared of thrombosis as a component of disseminated intravascular coagulopathy. Intensive insulin therapy to correct the hyperglycemic situation, and external cooling or antipyretics, for example, 650 mg to about 975 mg of acetaminophen, that could only be used for 2 days alone, 48 hours. You may choose to have mechanical ventilation if it is so required. Intravenous immunoglobulin, vitamin C, beta blockers or beta 2 agonists, and so on. Finally, it would be wise to put up a standing order. The standing order should be on what to look for, signs and symptoms of sepsis, when to report immediately, who to report to, the most responsible doctor in charge, or anyone on call that will be able to take decision immediately, and which immediate interventions will be required. That must be figured out based on your jurisdiction. Where to refer the patient. I've given an example. It could involve emergency room, intensive care unit, as the case might be. Prognosis, 10 to 50% mortality. That is very high mortality in these situations. The factors are, factors that could increase mortality will be post-discharge from the hospital. In other words, people that have been admitted in the hospital before and they are now down with sepsis will likely have more probability of mortality. How about host-related factors? For example, comorbid situations. Failure to develop fever or hypothermia might lead to wrong diagnosis. The age, because the older you become, the worse the situation, and the higher the probable mortality. Admission hyperglycemia. Someone that's been admitted with high glucose level and is now down with sepsis, definitely the glucose level will go off the roof. Bleeding dyscrasia before sepsis, because someone with bleeding dyscrasia and is now down with liver failure or with disseminated intravascular coagulopathy Then what are we talking about? Double barrel, synergistic effect negatively. Site of infection. The lower situation will occur if it is involving urinary tract infection as the site of the infection compared to gastrointestinal tract or pulmonary system with worse prognosis. The type of infection like nosocomial has a higher percentage of mortality compared to community-acquired situations, and the mortality will be higher in those with resistant multi-drug situations like penicillin resistant Staphylococcus aureus, vancomycin resistant Staphylococcus aureus, or vancomycin resistant Enterococcus, or extended spectrum beta-lactamase. Now, all these will lead to more mortality. Still on prognosis, antibiotics used. Depending on your selection, you may be using antibiotics, but you may not be winning if correct antibiotics have not been selected. And correct antibiotics will help a great deal. Restoration of perfusion. Failure to restore perfusion early is a pointer to a higher mortality probability. And with that, I've come to the end of sepsis production, either sepsis 1 and sepsis 2. If you can go over the two together, that will help to cover everything that I need to say or to present as far as sepsis is concerned. And I will say thank you for listening to my presentation. Kindly subscribe so that you can get these presentations immediately they're published. Thank you. I appreciate it.